You're listening to Heart-to-Heart Conversations, an unscripted discussion on today's hottest topics in interventional cardiology, with your host, Dejan Milasinovic. This podcast is brought to you by PCR.
Hello, everyone. It is a great pleasure to see you here today. This is the last edition of Heart-to-Heart Conversation for the year 2024, and I'm joined by a friend, Christopher Cook, from London. Chris, thank you for joining. It's a pleasure to have you here.
Oh, thank you for inviting me, Dejan. I can't believe the year is nearly over.
Yeah, it's true. So what we have as a plan for today, what we have prepared, is a discussion and update on what we have considered to be important topics in interventional cardiology over the year, with the most important trials of the year. The purpose today for the two of us is to have an overview of trends. What are the new things and what was new and what was added in 2024 in terms of data and how it impacts our practice. Don't forget that if you are following us on any of the social networks we are streaming, like X or LinkedIn, to visit the PCR Online website if you want to ask questions, because on PCR Online, you can ask questions all along the way. So I will now ask Chris to start explaining us what is his take on the main trials. Before that, let me show you what we prepared as the most impactful topics this year. So on the structural side, it's TAVI in asymptomatic patients, mitral repair in heart failure, and tricuspid interventions to improve quality of life. And on the coronary side, we are going to be speaking about the mechanical circulatory support in shock, with a danger shock trial, of course. Then the DCB for native disease. This topic has really dominated this year, and there was one large randomized trial, the BREC cage-free trial, which we will discuss. And then last but not least, class 1 indication for intracoronary imaging for complex PCI. That being said, I would like to ask you, Chris, to start with the structural side of the things and with our first topic, which is TAVI for asymptomatic severe aortic stenosis.
Great. Thanks, Dejan. I mean, it's amazing that we have randomized controlled trials addressing all three valves now. And as you say, I'd like to jump in really with what I think is the biggest trial of the year, certainly within the TAVR space, which was early TAVR. And just as a recap for the audience, this was a study of just over 900 patients who were asymptomatic severe aortic stenosis. And, the trial authors worked hard to make sure they were asymptomatic, with over 90% patients having a negative exercise tolerance test. This was a trial performed in the United States and Canada in a low surgical risk cohort. Now, the intervention here was so-called early TAVR with the balloon expandable SAPIEN system. And they were compared to the control group, which was the watchful waiting group. So what we normally do in clinical practice for asymptomatic patients. Now, the outcome, as you would expect, was a composite endpoint of death, stroke, or unplanned cardiovascular hospitalization, but crucially included what they call crossovers. So patients who went from the asymptomatic state into symptomatic and requiring TAVR, and that if that occurred within the first 6 months. And the median follow-up time here was just under 4 years at 3.8 years. And really, in terms of results, this is a strongly positive trial. We're not going to get too much into the data today, Dejan, but a hazard ratio of 0.5 was what was achieved with an early TAVR approach for the primary endpoint. Now, you may have seen on social media that people sort of transformed that absolute risk reduction into a number needed to treat of just 6 to prevent an event at 2 years. But there were some critiques of the study as well. We know that the study was neutral for mortality, and actually the primary endpoint was driven largely by those unplanned hospitalizations, which I mentioned earlier. So those patients that convert from asymptomatic into symptomatic and therefore needing aortic intervention. Thinking about this study, Dejan, I think there's a lot of people have given positives and negatives about it. for me, I'm fully supportive of this. And I think of it a lot like the unplanned revasc that we have in coronary intervention studies. You have an unblinded cohort. It is natural that unplanned hospitalizations, in my opinion, do drive the primary endpoint. But perhaps some of us were expecting to see mortality benefit from an early TAVR approach, as we have seen in the surgical literature. So the studies that have performed surgical aortic valve replacement in asymptomatic patients with high-grade aortic stenosis.
Yeah, I mean, Chris, you primarily focus on the structural interventions, and you know the community very well. So what do you think is the perception and the trend now? Do you think that from now on, we will increase TAVI presence in asymptomatic individuals? This being said, we need to acknowledge that in the early TAVR trial, there was close to 90% of patients within, let's say, the 4 years of the trial who ended up having TAVI in the conservative clinical surveillance group. Now, in contrast to that, 40% developed severe symptoms. So even patients without developing severe symptoms ended up having TAVI within the scope of the trial. Is this the trend we are facing? And if yes, and I think that this might be a trend, if yes, what is the cost-benefit ratio? Do we have problems with offering TAVI to a larger cohort of patients now, given that there are also some potential complications with the technique?
Well, look, first and foremost, as in my routine clinical practice, this study tells us clearly that an early TAVR approach is safe. Okay, so there was no signal of harm or penalty for performing TAVI sooner than you would conventionally otherwise do, i.e. in asymptomatic patients. What we also saw from the study, but wasn't perhaps widely reported, is that an early TAVR approach led to an improvement in ejection fraction. So there was less decline in ejection fraction from patients being left longer. Any TAVI operator who's listening to this will know that patients can so-called crash land. They can go from being completely asymptomatic and then end up in a very bad clinical situation. And in fact, we saw that in this study. 40% of patients presented either in pulmonary edema or with NYHA class 3 or class 4. Now, this puts great strain on in-hospital delivery of so-called inpatient TAVR, which puts huge financial pressure on the hospital systems. So my suspicion is that when you are treating patients in a safe way in the early TAVR trial, when they are compensated and well, my suspicion is that will be cost beneficial, actually, is my thought. But we look forward to see whether that analysis will come. So yeah, in summary, I do think it will inform my practice. I do expect to be having more referrals for patients with asymptomatic high-grade aortic stenosis. And in fact, now, I do think we have excellent quality data to say that this is both safe and effective and in line, most likely, with the patient's wishes, which is not to wait until they become very unwell, but actually to get ahead of the problem. Just one last point. I think this is a really, really important study to tell us that the progression from an asymptomatic state to symptomatic is actually quite fast. And so even if you do not adopt the early TAVR approach, you must make sure that your so-called watchful waiting strategies in your hospital are robust and that you do not lose these patients along the way and that you make sure that they are adequately followed up.
Great. Thanks, Chris. I mean, that's a wonderful summary. One last point. When we implant TAVI early, then the durability may become an issue as well, even more. And this will push us into the direction of developing strategies for that as well. That being said, on the coronary side, there was also a study which I think shook the community a bit. Earlier in the year at the ACC, danger shock was reported, showing that the microaxial flow pump, in addition to primary PCI, reduced mortality in patients with STEMI and related shock. Now, this, of course, is groundbreaking because shock patients are actually the hardest to treat. We know that the mortality rates ranged up to 50% in hospital or at the short term, and the previous trials failed to show any mortality benefit. So this was really an important trial. There are 2 points which I want to highlight, which have been raised over time when the trial was interpreted. One was the patient selection. The patients selected for this trial had high lactate levels, around 4.5 on average, but they also were patients who did not suffer coma after cardiac arrest. So if cardiac arrest was included, then Glasgow coma scale had to be higher than 8, which means that the patients which suffered hypoxemic brain injury were likely not included in the trial. And this by itself is an important contributor to death, to mortality of those patients. So eliminating those patients from the study may have allowed some of the effect of the circulatory support that we have seen. And the second important point from the trial is that the adverse events were higher in the group of patients receiving microaxial flow pump in addition to primary PCI, as opposed to having primary PCI alone. What does it mean? Renal replacement was around 40% in patients with the pump. And there were also a substantial number of patients with moderate or severe bleeding, around a quarter. And there was also 6% around of that kind of a number, limb ischemia, and roughly 10% sepsis. All those numbers meant that the patients were jeopardized but did not die. So this was an important point, that despite those adverse events being more frequent in the pump arm of the trial, the mortality still was less. Now, when we look at the numbers, the 30-day mortality was reduced from 47 in the control arm to 40% in the arm of the microaxial flow pump, and by 6 months, the rates were around 60 versus 50%. So the mortality still increases after hospitalizations in those patients with a substantial damage to the left ventricle. In summary, this trial, which, by the way, took 10 years to recruit, most of the patients were recruited from 2019, but the trial duration was 10 years, which I think adds information on how well the patients were selected over time. This trial does provide hope for what I would consider to be the most difficult patients in our cath lab, and that is infarct-related cardiogenic shock.
Yeah, I mean, I totally agree. These are the sickest patients in the hospital, and we do have a duty to try and find therapies to move that mortality in a positive way. And it's really exciting to see data supporting that in terms of a mortality benefit. But I guess my question to you, Dejan, about this study is, we can control so much of what we do in the lab. So we can put these devices in safely, we think. We can take care in how they're positioned in the left ventricle. But the signal for complications that you mentioned is an important one, and obviously an area for improvement. So how do we as a group get better at not just dealing with the management of these devices when we're putting them in the lab, but more specifically about the aftercare that happens in the intensive care unit or on the ward to get that patient to discharge in a good functional state?
Yeah, so I think that you could also see in the study that the patients who received the pump, that they spent more time in the CCU, in the ICU. And I think that the collaborative effort between interventional cardiologists and our colleagues who work at the ICU will be very important moving forward. But there are also things on our end which we can improve, like decreasing the sheet size, which may add to the safety side, decreasing the bleeding events. So I think this is the field that will be moving on. For me, the patient selection, so in which patient to use which device, because we know that the afterload may be a problem as well. Increased afterload due to vasoconstriction in the periphery may be a problem as well for the microaxial flow pump. So there are different variables which we need to take into account, both at the time of placement, the timing of the placement, for example, of the pump, but also, as you said, during the duration of the hospital stay, which altogether can improve the prognosis of those patients. All in all, I think it was a positive trial and a positive news for the most difficult group of patients that we face. That being said, I would like to ask you about mitral interventions. That's the next thing we would like to speak about. And there were two trials, and the Reshape trial, I think, was very interesting. What was your take on it? Mitral TEER for heart failure.
Yeah, I agree. I mean, a very interesting trial. And I think really interesting because it fits into a landscape of pre-existing data, which is actually contradictory. So you'll remember the COAPT trial, positive mortality and benefit for mitral TEER in functional MR with heart failure. And then the Mitra FR trial, which really didn't support those findings and was a negative. So just to recap, Reshape HF2 took over 500 patients who had functional mitral regurgitation, but actually moderate to severe. So the way that they described that is that 70% of them were actually less than truly severe MR. So it's a slightly different patient group with, of course, reduced ejection fraction. The intervention here was mitral TEER with the MitraClip device, and the comparator arm was conventional optimal medical therapy. The outcome was a composite endpoint of heart failure or death, and the time frame over which the study occurred was 24 months. And really, the headline news here is that this was a strongly positive study. We know we had big reductions in death and heart failure, so a 36% reduction, and a reduction in mortality of 25%, but it didn't make statistical significance, so P 0.09. And of course, we also saw quality of life improvements. So to me, in answer to your question that you started with, this is really interesting data because it adds more to our understanding of the role of mitral TEER in these heart failure patients with functional MR. And in fact, it begins to give pointers to the fact that maybe they don't have to be severe mitral regurgitation in order to see these impressive benefits against optimal medical therapy.
Yeah, this is interesting because when you compare a Reshape with a COAPT, there is actually a difference in the orifice area, which shows actually a less severe MR in the patients in the Reshape trial. So that being said, Chris, how do you see it? What is the next step in the evaluation of this data that we have now across 3 different randomized trials? COAPT, Mitra FR, and now Reshape.
Well, I mean, the clear thing that we need to do is to bring that data together in a robust way. We've already had sort of study level meta-analyses, but really this is crying out for patient level data. And that will really inform us as operators in discussion with our patients, because mitral valve patients are so heterogeneous, both in terms of their severity, but of course the anatomy as well. So TAVI always has the edge in terms of being a replacement therapy for what is quite a homogeneous condition, whereas mitral is very different to that. And so we have conflicting data out there. We think we're beginning to understand patterns and maybe patient selections that will benefit from TEER in this condition. But really, we need to see that data brought together at a patient level to really understand who to target in order to get the benefits.
Thank you, Chris. So the next segment is again on the coronary side, and I would like to introduce to everybody REC-CAGE-3 1 trial. And this was a trial conducted in China, which was a non-inferiority trial that compared a DCB strategy versus a DES strategy in coronary lesions. So patients were 50% ACS, but only 15 to 16% were STEMI. So half were elective, half were ACS, but mostly non-STEMI patients. And those were non-complex coronary lesions. Here, what we saw was an increase in TLR, target lesion revascularization, in patient treating with DCB, which led to the overall conclusion that DCBs are not non-inferior, hence they are inferior to drug-eluting stents. So this was, let's say, a first major trial, randomized trial, which suggested this. The previous one was Basket 2 trial, which suggested that there was no significant difference between a DCB and the DS strategy. But the difference was that the Basket 2 trial was conducted mainly in patients with small vessel disease below 3 millimeters diameter. Now, the REC-CAGE-3 1 trial was, of course, different, and it involved patients with small and large vessels, so below and above 3 millimeters. And the difference was noted in those patients with large diameters, above 3 millimeters. So this has driven the trial to the conclusion that you can appreciate, and that is that the DCB was inferior. It was inferior, but in a subgroup of patients with large diameters. Now, that being said, I think that an important point here to discuss and to think about is that when we treat a patient with a DCB strategy, we need to make sure that we do not leave residual ischemia behind. If we treat a proximal vessel, which is going to be rather of a larger diameter, then we are more likely to relieve residual ischemia. So it's important to make sure at the end of the procedure, perhaps, and this is something which could be an argument for physiological guidance, not to leave a lot of residual ischemia, because the patients will come back with a chest pain on the non-invasive testing. We will show inducible ischemia, and they will go back to the cath lab, and we may need to redo the procedure. And this is exactly what was reflected by the trial data. So I think that the physiological guidance may be important part of the DCB development story.
Yeah, it's a really interesting point, isn't it? I mean, the whole DCB story in itself is interesting, and the fact that we've almost gone full circle, having, very high performing latest generation stents, but still thinking that actually there may be a better or additive role for just drug-coated balloon therapy rather than caging the vessel. So I guess, there's lots of buzz, for want of a better word, about DCBs, a big change in practice in some places. Where do we go from here, Dejan? Are we waiting for further studies? Will you change your practice on the basis of the trial data that's already out there about drug-coated balloons?
Yeah, I think, seeing that there was no difference in the subgroup of small vessel disease, and given the prior data, I think its use will be continued with the small vessels. And I think there are two principal factors which will determine the further pathway. The one is the issue of the class effect. So this was a balloon from China, and the trial was conducted in China. It was a paclitaxel-eluting one, but the excipient might have been different from some other balloons which we have, which are also paclitaxel-eluting. And also, there are different drugs available. We know that there are sirolimus, even biolimus-based balloons. There is a large trial which is upcoming in the next year, solution trial, which is a sirolimus-based balloon. So a class effect cannot be, let's say, assumed for all these trials. And I think this is one area of discussions for the future. And the other area of discussions, I think, will be about how we understand and design future trials. Are those strategy trials? And I would urge everybody who is interested in this field to look at the PCR webinars, especially at our latest series on DCBs, where there is a debate where Professor Bruno Scheller, who is one of the pioneers in the field, actually made a very nice comment about the design of the trials that might need to be strategy trials. So a strategy of DCB versus a strategy of DES only, which would mean that you do not use DCB alone. You use it when needed in addition to DES, so that the future will be mixed with a mix of DCB and the DES for different patients and for different clinical situations. That being said, Chris, we come to the final segment, and here we have actually big news in an area which is not necessarily preserved or has not been within the focus of our community, and that's the tricuspid valve. So what do we have here which was new in 2024?
Well, we've got a huge study here, which is TRISCEND-2, which took 400 patients with severe tricuspid regurgitation and essentially randomized them to transcatheter tricuspid valve replacement. So not repair, but replacement with the Evoke system from Edwards Lifesciences. And the comparator here was patients who were continually managed on optimal medical therapy. Now, the endpoint here for the study was a hierarchical endpoint. At the top end of that, you've got very hard endpoints like death, implantation of ventricular assist devices, etc. And then in the middle, you've got your symptom improvements as well. And this was conducted over the time space of 1 year. And what we know from the study is that this was a positive for that primary endpoint. So it came up with a win ratio that was in favor of having your tricuspid valve replaced percutaneously. And the way that distills down is that the majority of those wins, if you want to call it that, were on symptomatic grounds. So we're talking here KCCQ, NYHA class. Now, there also were some losses, and those were losses in terms of procedural complications with regards to major bleeding and a need for pacemaker implantation. And then it was neutral for the harder endpoints such as mortality and heart failure readmission. But some really other interesting points here is that there was 95% procedural success in this highly innovative and new therapy, which led to, by and large, the complete elimination of tricuspid regurgitation. And most of these procedures were performed in under an hour. So in summary, this is the first randomized controlled trial of any form of tricuspid replacement technology percutaneously. It was strongly positive on issues and factors regarding quality of life. And it seemed to point to areas where we can focus on. So patients who have preserved right ventricular function seem to do better. And so perhaps we can target our therapies more in future randomized clinical trials.
Thank you, Chris. So, this is a space where we, with the current data, can provide symptom relief to the patients. So when we have a severe tricuspid regurgitation, we can speak with the patients, and what we can say based on the current data is that the symptom relief is to be expected if we treat them percutaneously. Now, where do we go from here in the development of this therapy? What's your thought on that?
So I think we've got some interesting pointers as to where to go from here. A bit like when we were talking about danger shock. I'm less worried about procedural complications because in time they will be refined. And we already know from the post-market release data that actually the bleeding risk associated with this device is far less now, presumably from withdrawing aspirin in combination with anticoagulation. So I think as a field, we will get on top of the complication issues. I have no doubt about that. I think this study does give us important targets for future patients. And really, I worry that in this study, we left these patients too long. They had very, very severe, massive tricuspid regurgitation, big dilated, poorly functioning right ventricles. So really, we need to improve on the complications, which I think we will do. And I think we need to probably target patients earlier in their disease process. And ultimately, the replacement technology fits nicely in with the repair tier technology for the tricuspid side, so that really patients now have many more options than they ever have done previously.
Thank you, Chris. So now we come to the last segment, and that is the last subtopic of the coronary part. And with this, I would like also to close because we've revisited 5 major trials from year 2024. And this also happened in 2024, which is a class 1 indication for intracoronary imaging. And this shows that the trials, as they accrue over time, and as we try to interpret them and put them into the clinical context, do at the end, or may at the end, receive their validation through a formal recommendation by large societies, like this is the case. So in 2024, ESC recommends IVUS or OCT for complex PCI. Specifically, they name bifurcations, left main and long lesions, and this is a class 1 with a level of evidence A. There have been actually many trials and many meta-analyses of the trials pointing into this direction. One of the most recent ones was the October trials in the field of bifurcations, which showed that the OCT guidance was associated with better outcomes. So now it's the question, class 1 means routine. So are we ready for routine intracoronary imaging in patients undergoing complex PCI? And I see 3 issues here, which I think will be discussed in the future. The first is the definition of complex PCI, of course. The guidelines mention the bifurcations, the left main, But we actually don't have a randomized trial in the field of the left main. Next year, we will, I hope, have the publication of the dedicated imaging-guided left main PCI trial. So we'll know more about that. But there are different aspects to complex PCI, and the calcified lesions, for example, is a domain which also may be seen as a complex PCI and where intracoronary imaging helps. So the first idea is to better define the complex PCI, I think, going from here. The second is to better understand how imaging helps. We already said October trial, OCT in bifurcations helped, but the question is how? Was it because we were chasing a parameter, a single parameter like expansion? Or was it a set of parameters like edge dissections, landing zones, apposition, expansion? Or was it even on a higher level, an imaging-based approach which entails imaging-based understanding of the anatomy at baseline and throughout the procedure, which is much more comprehensive than a single guiding reference point such as expansion? And that may be true. It may be true that if you use imaging over time, you note a lot of different variables which for a given patient are of a great value. In bifurcations, it's abdominal rewiring, for example. If you want to rewire the side branch and you go behind the stent struts of the main vessel stent, you can crush the stent, you can distort the architecture and cause events down the road. And the third point, I think, which is at the moment, I think the most acute one, is adoption. Having a class 1 recommendation gives us a lot of strength to push for more adoption, given that the adoption is not even. It is very heterogeneous across the world, even inside Europe. And on the other hand, we don't really understand all the factors contributing to the low adoption. And there are groups like the one led by Javier Escanet who are trying to explore the factors that lead to the under-adoption of intracoronary imaging. Chris, what do you think about this class 1 recommendation?
Well, I think a very simple comment is it's been a long time coming, and it's great to see the power of science in order to develop and understand a rationale for doing something which, prior to these guidelines, many people had very strong opinions about. And now, from the weight of the research, from the rate of the science, and from the key opinion leaders, it's fantastic to see that their committees have realized that. And as you say, Dejan, it's up to us as a community now to take those recommendations and make sure that we enact them clinically.
Thank you very much. Very nice ending to this special edition at the end of the year. I thank you once again greatly for being with us. I thank Chris for his participation. It was great. And I want to wish everybody happy festivity seasons, Merry Christmas, and all the best for the new year. Thank you, Chris. Thank you, everybody.
Thank you, Dejan. Bye-bye.
Thank you for listening to this heart-to-heart conversation. Find out more about upcoming dates and replays of recent conversations on pcronline.com.